Alright, this week we're covering Chapter 14. It covers psychological disorders. How are psychological disorders conceptualized and classified? First, we'll talk about psychopathology. This is a sickness or disorder of the mind, a psychological disorder. Etiology is a term for factors that contribute to the development of a disorder. Views on psychopathology have changed over time. Earliest views of psychopathology explained apparent madness as resulting from possession by demons or evil spirits. In the latter half of the Middle Ages and into the Renaissance, people with psychopathology were removed from society so they would not bother others. In 1793, a psychologist named Pinel, or scientist named Pinel, removed patients from their chains and banished physical punishment. He instituted what came to be known as moral treatment, a therapy that involved close contact with and careful observation of the patients. Throughout history, people believed that gods, witches, or evil spirits caused psychological disorders. I'm glad we don't live in those times anymore. Hippocrates, often credited as the founder of modern medicine, classified psychopathologies into three categories: mania, which are delusions, activity level, and excitement; melancholia, which is depression; and phrenitis, which is mental confusion. Hippocrates believed that such disorders resulted from the relative amount of humors, or bodily fluids, that a person possessed. Having too much black bile led to melancholia, or extreme sadness and depression. During the last 200 years, recognition has grown that psychopathology reflects dysfunction of the body, particularly of the brain. Although environmental factors are important, we now understand that biology plays a critical role in many psychological disorders, especially disorders such as bipolar or schizophrenia. Psychological disorders as maladaptive. In determining whether behavior represents psychopathology, it is important to consider certain criteria. Does the person act in a way that deviates from cultural norms for acceptable behavior? Is the behavior maladaptive? Is the behavior self-destructive? And does the behavior cause discomfort and concern to others? Psychopathology is increasingly defined in terms of maladaptiveness. Psychopathology is common in contemporary society. Psychological disorders are common and account for the greatest proportion of disability in developed countries. Mental disorders range in severity. About 1 in 4 Americans over the age of 18 has a diagnosable psychological disorder in a given year. About 1 in 5 adults receives treatment over any 2-year period. And only about 7% of the U.S. population is severely affected, and this group also tends to suffer from multiple disorders. Drawing the line between a normal emotional experience and a mental disorder can be difficult. If particular symptoms seem to describe anyone you know or yourself perfectly, resist the urge to make a diagnosis. Just like medical students who worry they have every disease they learn about, you need to guard against overanalyzing yourself and others. Another aspect is not to diagnose other people. It's referred to as armchair diagnoses. If you don't have them in person and have training yourself, a diagnosis is not appropriate. Psychological disorders are classified into categories. In the 1800s, a scientist named Kraepelin identified mental disorders on the basis of groups of symptoms that occur together. In 1952, the American Psychiatric Association published the first edition of the Diagnostic and Statistical Manual of Mental Disorders, the DSM. In the current edition, the DSM-5, released in 2013, disorders are described in terms of observable symptoms. Kraepelin was one of the first researchers to propose this classification system for psychological disorders. Here's a picture of him. A client must meet specific criteria to receive a particular diagnosis. The DSM-5 consists of 3 sections. First is an introduction with instructions for using the manual. Second is diagnostic criteria for all of the disorders, which are grouped so that similar categories of disorders are located near each other. Third is a guide for future psychopathology research, which also includes conditions not yet officially recognized as disorders. Here's a list of DSM-5 disorders, categories. This is from the book, so you can go and check that out if you want, or hit pause on this and read through it. There's a dimensional nature of psychopathology. In the 3rd section of the DSM-5, researchers are encouraged to examine whether a dimensional approach might be helpful for understanding many psychological disorders, particularly personality disorders. Research indicates that personality disorders can be viewed as maladaptive extremes of the Big 5 personality traits. Symptoms of psychological disorders occur along continuums. They are not absolute states. It's not just a black and white situation. There are gray areas. A person who falls below the cutoff level may not meet the diagnostic criteria, but may still experience symptoms that interfere with his or her life and will therefore benefit from treatment. Comorbidity. Another problem with the DSM approach is that people seldom fit neatly into the precise categories provided. Many psychological disorders occur together, even though the DSM-5 treats them as separate disorders. For example, depression and anxiety, or depression and substance abuse. This state is known as comorbidity. It is possible that psychological disorders are comorbid because of common underlying factors. It has recently been proposed that psychopathology reflects a common general factor analogous to general intelligence, or G. In this case, a P factor. Higher scores on the P factor were associated with more life impairment, such as suicide attempts, psychiatric hospitalizations, and criminal behaviors. High P scores also predicted a worsening of impairments over time. Just as the G dimension of intelligence reflects low to high cognitive abilities, the P dimension reflects low to high psychopathology severity. Psychological disorders commonly overlap. For instance, substance abuse is common across psychological disorders, and people with depression or a milder form known as persistent depressive disorder often also have anxiety disorders such as panic disorder or generalized anxiety disorder. Research domain criteria. The U.S. National Institute of Mental Health, the NIMH, has proposed an entirely new way of classifying and understanding psychological disorders. Whereas the DSM approach classifies disorders by observable symptoms, the research domain criteria, this is a method that defines basic aspects of functioning and considers them across multiple levels of analysis, from genes to brain systems to behavior. The RDOC initiative is initially meant to guide research rather than to classify disorders for treatment. This approach capitalizes on recent advances in genetics, neuroscience, and psychology in understanding adaptive behavior, as well as how functioning can be disrupted by various disorders. The ultimate aim of the RDOC initiative is for the classification and treatment of psychological disorders to be based on the underlying biological and psychosocial causes. Some critics of the RDOC argue that it is moving too quickly and that an abrupt shift in diagnostic criteria is no guarantee for better treatment results. Others worry that this initiative is focused on the neuroscience at the expense of understanding personal experience. Within the United States, because the NIMH funds the majority of research, RDOC will be the driving force for research on psychopathology. Alright, here's a handy graphic from the book that you can check out. Pause this and read that if you want. It kind of breaks it down a little bit. Assessment. Determining whether a person has a mental disorder is not as straightforward as most medical diagnoses. An assessment in psychology is an examination of a person's cognitive, behavioral, and emotional functioning to diagnose possible psychological disorders. This process often includes self-reports, psychological testing, observations, and interviews. It may also involve neuropsychological testing. In the neuropsychological method, the client performs actions such as copying a picture, drawing a design from memory, sorting cards that show various stimuli into categories based on size, shape, or color, placing blocks into slots on a board while blindfolded, and tapping fingers rapidly. By highlighting actions that the client performs poorly, the assessment might indicate problems with a particular brain region. The assessment depicted here uses a neuropsychological test to examine mental function. In this timed test, a researcher watches a client fit wooden blocks into a corresponding template to test for signs of Alzheimer's disease. Often a medical evaluation is indicated. For instance, the symptoms of depression or anxiety disorder can be similar to those of hypothyroidism, an endocrine disorder that should be ruled out before a psychological disorder is treated. The primary goal of assessment is to make a diagnosis so that appropriate treatment can be provided. The course and probable outcome or prognosis will depend on the particular psychological disorder that is diagnosed. Ongoing assessment helps mental health workers understand whether specific situations might cause a worsening of the disorder, whether progress is being made in treatment, and other factors that might help in understanding unique aspects of a given case. Clinical psychologists examine a person's mental functions and psychological health to diagnose a psychological disorder and determine appropriate treatment. This flowchart shows the factors that lead to treatment. Evidence-based assessment. A key question is whether psychological assessments provide information that is useful for treating psychological disorders. Popular methods of assessment, such as projective tests, have not been shown to be helpful in predicting the kinds of treatment that are useful. Individual clinicians often choose assessment procedures based on their own subjective beliefs and training rather than based on scientific studies. Evidence-based assessment is an approach to clinical evaluation in which research guides evaluation of psychopathology. The selection of appropriate psychological tests and neuropsychological methods, and the use of critical thinking in making a diagnosis. Evidence-based assessment approach would indicate that people found to be depressed should be assessed for comorbid conditions such as substance abuse. Psychological disorders have many causes. Biological and environmental factors are thought to play important developmental roles in psychopathology. The diathesis stress model is a diagnostic model that proposes that a disorder may develop when an underlying vulnerability is coupled with a precipitating event. The onset of psychological disorders can be seen as resulting from the interactions of a diathesis and stress. The diathesis may be biological, for example, genetic predisposition, environmental, for example, childhood trauma, or both. Biological factors. The biological perspective focuses on how physiological factors contribute to psychological disorders. In genetics, genetic factors can affect the production and levels of neurotransmitters and their receptor sites. Genetic factors can also affect the size of brain structures and their level of connectivity. Some disorders may arise from prenatal problems, such as malnutrition, exposure to toxins, and maternal illness. During childhood and adolescence, environmental toxins and malnutrition can put an individual at risk for mental disorders. Biological factors may contribute to mental disorders because of their effects on the central nervous system. Functional neuroimaging is currently at the forefront of research into neurological components of mental disorders. PET and fMRI have revealed brain regions that may function differently in individuals with mental disorders. These brain MRIs are from twins. The twin on the right has schizophrenia, and the one on the left does not. In the MRI of the twin with schizophrenia, note that larger ventricles, these fluid-filled cavities, appear dark in the image. The same pattern has emerged in the study of other twin pairs in which one has schizophrenia and the other does not. Thus, the brain may be deteriorating over time for those with schizophrenia, and this finding tells us that the biological factors may be important in understanding schizophrenia. Situational factors. Situational factors play an important role in the expression and treatment of mental disorders. The family systems model is a diagnostic model that considers problems within an individual as indicating problems within the family. Sociocultural model is a diagnostic model that views psychopathology as a result of the interaction between individuals and their cultures. There are cognitive behavioral factors. In the cognitive behavioral approach, a diagnostic model that views psychopathology as the result of learned maladaptive thoughts and beliefs. The central principle of this approach is that abnormal behavior is learned and thus can be unlearned. Proponents of strict behaviorism argue that mental disorders result from classical and operant conditioning. The premise of this approach is that thoughts can become distorted and produce maladaptive behaviors and maladaptive emotions. Psychological disorders vary by gender and by culture. Some disorders, such as schizophrenia and bipolar disorder, are equally likely in the genders, whereas other disorders vary between the genders. Dependence on alcohol is much more likely in males, whereas anorexia nervosa is much more likely in females. The bars on this graph represent how common particular psychological disorders are for men and for women. For that one there on anorexia, note that these relative rates do not reflect the frequency of the disorders in the population. For example, anorexia is much more likely in women than in men, but is relatively uncommon in the population. One way of categorizing mental disorders is to divide them into two major groups. Internalizing disorders are characterized by negative emotions, for example, major depression, generalized anxiety disorder, and panic disorder. Externalizing disorders are characterized by disinhibition, for example, alcoholism, conduct disorders, and antisocial behavior. In general, the disorders associated with internalizing are more prevalent in females, and those associated with externalizing are more prevalent in males. This diagram divides disorders into two basic categories, internalizing and externalizing. It also divides internalizing disorders into those related to fear and those related to distress. Cultural syndromes. Most mental disorders show both universal and culture-specific symptoms. Disorders with a strong biological component will tend to be more similar across cultures. A disorder heavily influenced by learning, context, or both is more likely to differ across cultures. For example, depression is a major mental health problem around the world, but the manifestations of depression differ by culture. Since the 1994 edition, the DSM has included a number of disorders that tend to occur within specific cultural settings. Clinicians and researchers need to be sensitive to cultural issues to avoid making mistakes in their diagnoses and treatments. Here's a list of cultural syndromes Some of these might be difficult to pronounce. This is also from the book, or you can pause here to read through that. Which disorders emphasize emotional states? When emotions or moods go from being normal part of daily living to being extreme enough to disrupt people's ability to work, learn, and play, these states are considered symptoms of psychological disorders. Anxiety disorders make people fearful and tense. Anxiety disorders are psychological disorders characterized by excessive fear and anxiety in the absence of true danger. By continually arousing the autonomic nervous system, chronic anxiety also causes bodily symptoms such as sweating, dry mouth, rapid pulse, shallow breathing, increased blood pressure, and increased muscular tension. Chronic arousal can also result in hypertension, headaches, and other health problems. More than 1 in 4 Americans will have some type of anxiety disorder during their lifetimes. Because of their high levels of autonomic arousal, people who have anxiety disorders also exhibit restless and pointless motor behaviors. Exaggerated startle response is typical, and behaviors such as toe tapping and excessive fidgeting are common. Research has shown that chronic stress can produce atrophy in the hippocampus, a brain structure involved in learning and memory. The various anxiety disorders share some emotional, cognitive, somatic, and motor symptoms, even though the behavioral manifestations of these disorders are quite different. All right, here are the 5 types of anxiety disorders. There's specific phobia, social anxiety disorder, generalized anxiety disorder, panic disorder, and agoraphobia. You can read through this graph. It's also from the book, or you can pause this. All right, now we're going to talk about each one of those in detail. In the DSM-5, people are diagnosed with specific phobia based on the object of the fear. Specific phobias affect about 1 in 8 people and involve particular objects and situations. Common specific phobias include fear of snakes, ophidiophobia, fear of enclosed spaces, claustrophobia, and fear of heights, acrophobia. Another common specific phobia is fear of flying. Here's a list of some unusual specific phobias. It's kind of hard to choke through these words, but my favorite is the long word, which is fear of long words. That one cracked me up. Some of these are funny. You should read through them. Social anxiety disorder. This is formally called social phobia and is the fear of being negatively evaluated by others. This includes fears of public speaking, speaking up in class, meeting new people, and eating in front of others. It is one of the earliest forms of anxiety disorder to develop, often beginning around age 13. The more social fears a person has, the more likely he or she is to develop other disorders, particularly depression and substance abuse problems. As this diagram illustrates, social anxiety disorder is comorbid with many other psychological disorders. If a client has social anxiety disorder, all of these disorders need to be considered to make an accurate and complete diagnosis. Generalized anxiety disorder, or GAD, is a diffuse state of constant anxiety not associated with any specific object or event. People with this disorder are constantly anxious and worry incessantly about even minor matters. Hypervigilance results in distractibility, fatigue, irritability, and sleep problems, as well as headaches, restlessness, lightheadedness, and muscle pain. Just under 6% of the United States population is affected by this disorder at some point in their lives. Women are diagnosed more often than men. Panic disorder is an anxiety disorder that consists of sudden, overwhelming attacks of terror. Panic attacks typically last for several minutes, during which the person may sweat and tremble, feel his or her heart racing, experience shortness of breath, feel chest pain, and feel dizzy and lightheaded with numbness and tingling in their hands and feet. People feel that they are going crazy or that they are dying, and those who suffer from persistent panic attacks attempt suicide much more frequently than those in the general population. This affects an estimated 3% of the population. Women are twice as likely to be diagnosed as men. Agoraphobia. This is an anxiety disorder is marked by fear of being in situations in which escape may be difficult or impossible. This is something I feel anytime I ever go to a UK game at Rupp Arena. For example, they may fear being in a crowded shopping mall or using public transportation. Their fear is so strong that being in such situation causes panic attacks. A clear link between panic attacks and agoraphobia exists. Development of anxiety disorders. The first factor is biased thinking. When presented with ambiguous or neutral situations, anxious individuals tend to perceive them as threatening, whereas non-anxious individuals assume they are non-threatening. Anxious individuals also focus excessive attention on perceived threats. The second factor is learning. A person could develop a fear of flying by observing another person's fearful reaction to the closing of cabin doors in an airplane. There is also a biological factor. Children who have an inhibited temperamental style are usually shy and tend to avoid unfamiliar people and novel objects. These inhibited children are more likely to develop anxiety disorders later in life. Unwanted and intrusive thoughts increase anxiety. Having these unwanted thoughts leads to emotional distress and anxiety. The DSM-5 categorizes a number of disorders together that involve experiencing unwanted thoughts or the desire to engage in maladaptive behaviors. The commonality is an obsession with an idea or thought, or the compulsion to repeatedly act in a certain way. Related disorders in this category include people chronically pulling at their hair or picking at their skin, people being obsessed with deficiencies in their physical appearance, and hoarding disorder. Which leads us to obsessive compulsive disorders, or OCD, as it is very commonly referred to. This is a disorder characterized by frequent intrusive thoughts and compulsive action. The most common disorder in the DSM-5 category is OCD. This affects 1% to 2% of the population and is more common in women than men. Obsessions are recurrent, intrusive, and unwanted thoughts or ideas or mental images that increase anxiety. They often include fear of contamination or of accidents or of one's own aggression. Compulsions are particular acts that the OCD patient feels driven to perform over and over that reduce this anxiety. The most common compulsive behaviors are cleaning, checking, and counting. Those with OCD anticipate catastrophe and loss of control. This flowchart illustrates the operations of conditioning for the example given in the text. Classical conditioning step 1 and operant conditioning steps 2 and 3 reinforce behavior. Continued reinforcement may continue to a person's developing OCD. Causes of OCD. A paradoxical aspect of OCD is that people are aware of their obsessions and compulsions and that they are irrational, yet they are unable to stop them. One explanation is that the disorder results from conditioning. There is also good evidence that the etiology of OCD is part genetic. Various behavioral genetic methods, such as twin studies, have shown OCD runs in families. Brain imaging has provided some evidence regarding which brain systems are involved in OCD. The caudate, a brain structure involved in suppressing impulses, is smaller and has structural abnormalities in people with OCD. There is also growing evidence that OCD can be triggered by environmental factors. A streptococcal infection apparently can cause a severe form of OCD in some young children. Treatments that enhance the immune system have been found to diminish the symptoms in OCD in children with the syndrome. Post-traumatic stress disorder, or PTSD. The DSM-5 categorizes a number of disorders together that result from trauma or excessive stress. This category describes trauma and stressor-related disorders. A person who cries continually, has difficulty studying, and avoids social settings 6 months after a romantic breakup may have an adjustment disorder. Post-traumatic stress disorder, or PTSD, is a disorder that involves frequent nightmares, intrusive thoughts, and flashbacks related to an earlier trauma. At Northern Illinois University in 2008, a lone gunman killed 5 people and wounded 21. Among a sample of female students, those with certain genetic markers related to serotonin functioning were much more likely to show PTSD symptoms in the weeks after the shooting. Those with PTSD often have chronic tension, anxiety, and health problems, and they may experience memory and attention problems in their daily lives. PTSD involves an unusual problem in memory, the inability to forget. The lifetime prevalence of PTSD is around 7%, and women are more likely to develop the disorder. Depressive disorders consist of sad, empty, and irritable moods.